going to speak about ventilator-induced lung injury, and I want to perhaps go away from being a clinician for a moment and thinking about evidence-based medicine, being a little more scientific and trying to root out the fundamental problem, trying to define the problem perhaps a little more precisely. We have some concepts, the baby lung, low tidal volume, we have to get the right PEEP setting. All these concepts are important, but when you get into the clinical world, as we just found out, there's different response to this. And so at some point, we need to understand the basic mechanism of the process. Now, there's a lot of studies, but we do know that currently we are still in the same position we were before. You can go back many, many years. We still have a supportive therapy for this type of respiratory failure. I'm not sure it's the same in all patients, but we lump all the patients together, so we do have those mixed cases. And so it makes it harder to understand what's going on clinically. If you look at all the studies that have been done, I don't know that we're going to improve our basic understanding from just interpreting clinical studies. In fact, this was another comment recently about before we go on, we may need to just understand a little bit more precisely the pathophysiology about what's going on. And in fact, again, if we don't understand enough, we don't even know the right question to ask of a clinical trial. So remember, a clinical trial or evidence-based medicine is statistical methodology. That's it. That's what it is. It assumes that you have the right question. It assumes that you have some mechanistic, basic understanding that is biologically plausible. And that way you can infer, never prove, a causal relationship. I think this is important because we assume just because something is published and it's evidence-based and it's randomized controlled trial, therefore it proves something. It really doesn't. So again, let's not be clinicians for a moment. Let's try to be a little more scientific. And let's start with some of the assumptions that have been made over the years and whether they actually have been proven, yet need to be proved, should be proved, is not even a relevant question. All of these things become important. Now, of course, the whole idea of low tidal volume, there's a history that goes way back to even not overventilating asthmatic patients. This was done in the early 80s. Dräger was publishing data on asthmatic patients and lowering their tidal volumes. This was adopted by Keith Hickling in New Zealand and using ultimately lower tidal volumes at a high rate and producing permissive hypercarbia. These concepts all ultimately evolved into the idea that we should limit the amount of volume going into the lung because it's a diseased lung. It can't accommodate the same sort of tidal volumes. And so we have this idea of the baby lung now, because CAT scans have certainly showed us that the baby lung, when you look at it radiographically and you use Hounsfield units, you can tell the difference between an aerated lung and a non-aerated lung. I wouldn't say it gives us much more detail than that, but at least it's a start. And it showed that we shouldn't just ventilate the lung because globally it has low compliance and we just simply need to use more pressure. That's all you need to do. That was certainly the thoughts at one point of mechanical ventilation. That the lung is stiff, therefore we just need more pressure and we can normalize it, we can normalize the blood gases and so on. But certainly CAT scans have helped us understand it. But one thing that's important is the idea of volumetric distortion of the lung is one of the concepts that allows us to sort of look at the baby lung. Thank you, Luigi, from previous. But you can see, again, on a CAT scan, you see what we would call the baby lung. Again, originally described actually in 1986. And you can see that it doesn't account for severity of disease and actually might have nothing to do with body weight at all. In fact, that may be another sort of problem we have, but we won't go into that particular part. But the whole idea is to protect the lung, because if you over-distend that baby lung, you're going to completely damage it and so on. So that's the concept. And of course, we know that this is the landmark study that showed that there was a survival difference between 6 and 12. I will tell you there was some data published around this study also that showed 10 and 6 were identical. It's published data through the Freedom of Information Act, actually more than 2,000 patients that they followed that were originally excluded from the study only because of variables like enrollment time, or physician didn't want them, or family members didn't want, but they met criteria. But they were managed with traditional tidal volume of 10 mL, so there's no difference between 6 and 10. Now that's sort of on the back pages, so we don't always think about that. But anyway, here's the conclusion of that study. Now there's no doubt there's a statistical mortality difference between 6 and 12. But this is the conclusion, and I will just tell you there is no mechanistic data that proves stretch at all. That by lowering tidal volumes, you're actually limiting the stretch of the lung. Now, I'm not saying that this conclusion is invalid. I'm not saying that at all. What I'm saying is that if you want to look for a mechanism, a biological plausibility that this is actually what's happening, rather than the concept of a CAT scan where you have a baby lung and you believe that the air will go there versus somewhere else, then you might assume along these lines of thinking. And so what happens? What happens if we look at it a little bit differently? Luigi already showed us this data, but reproducibility is still an important aspect of science. Still an important aspect. You know, I should be able to do an experiment, you should be able to reproduce it. So for whatever reason, you take this is a meta-analysis of 9 major studies, and we're looking at the 3,500 patient variables. So it's a meta-analysis not of studies, but of patients, which is actually, I think, important. But there was no mortality difference with plateau or tidal volume. I mean, if that was the causal reason why there was a mortality benefit of 6 versus 12, then we should have been able to reproduce that, but we didn't. Again, I'm not saying this proves anything other than it raises questions that, you know, I think probably deserve a little more thought, a little more question about. Now, again, one of the problems I think we have is we generally have these 2 major ideas about ventilator-induced lung injury. Let's just assume it occurs. And the question is, one is stretching the baby lung, overstretching the lung, and the other is recruitment, de-recruitment. Those are by far the 2 prevailing concepts. And you can almost think of them as separately. Again, the baby lung is going to be overdistended, and the recruitment, de-recruitment is going to happen in the more dependent parts of the lung. And actually, this is a CAT scan. This is 6 mLs per kg. You can see that. But the problem is we don't separate them. We don't really say that, well, overdistension is responsible for 90% of ventilator-induced lung injury and 10% is from recruitment, de-recruitment, or the other way around. We don't quantify it, and we haven't even described it at a certain level beyond the sensitivity of the CAT scan. So if we look at 6 mLs and we look at 12 mLs, watch what happens. 12 mLs, you actually recruit. So remember, you're working your way up to a plateau pressure. You can't really isolate. None of the animal studies, none of the clinical studies have isolated recruitment, de-recruitment from overdistension. Overdistension is the final plateau phase. But on the way up to the plateau phase, you could be opening up the lung quite a bit. In fact, let's take a look at some alveolar microscopy. Watch what happens. Every time you cycle a tidal volume, and this is with PEEP. So you can't really separate recruitment, de-recruitment from distension. So which is it? And more importantly, I can't tell you the other possibility is not valid and not offer you an alternative explanation. So I'm going to offer you an alternative explanation. I don't know if this is true or not, but at least an alternative explanation is that when you look at 6 versus 12, we know that the plateau pressure is higher. This is the mean plateau pressure in both studies. And if you look at this, the idea here is that what you're doing by going to 6 mLs is actually stopping the recruitment and de-recruitment. You're actually not changing distension. In fact, the data suggests the other way around, that the normal lung, its architecture, is completely resistant to overdistension at the alveolar level. That there's no alveolar overdistension in normal lung tissue. In fact, alveoli get smaller as you get to total lung capacity. So could this be an alternative, that what you're doing is you are penetrating less into that diseased part of the lung, and you're now opening it and closing it. And if you use 6 mLs, you might leave lung that's completely collapsed throughout the cycle. And therefore, technically, collapsed lung never even sees the ventilator. So maybe that's one of the things that's important. Again, I'm not telling you that I know the answer. Believe me, I don't. I'm just offering this out as, for us to be more scientific about this, we need to ask some questions. In fact, here's a study that suggests, and this goes into, when we think about even an editorial that was written by Roy Brower about how we need to put open lung strategies to rest so that everybody can move on, and open lung strategies don't work, i.e. the ART trial failed miserably. We look at these things and we make more assumptions. We assume that if you use enough PEEP that you've recruited the lung. And in fact, the standard 30 of plateau and 15 of PEEP leaves a lot of lung recruiting, de-recruiting. In fact, I would say that we've lost the idea that even PEEP, what is the point of PEEP? The original intent of PEEP, which actually in the early, in the 67 paper that we know classically as Ashbal-Petty, it's actually a paper about PEEP, even though we call it as the first description of ARDS, which is also not true. But we think about PEEP, and we think of PEEP and oxygenation. As soon as you think about PEEP, you think of oxygenation. That wasn't the intent of PEEP at all. The intent of PEEP is to keep the lung from closing at end expiration. That was the whole idea of PEEP. It's not about oxygenation. In fact, if we look at PEEP, and this is an injured lung, alveolar microscopy, and you can see the alveoli completely collapse. And we're going to go to 5 of PEEP. Now watch what happens with 5 of PEEP. 5 of PEEP now. There it is. Now watch what happens. The PEEP effect is going to disappear. In fact, the lung is always redistributing its pressures. In fact, I would tell you that PEEP may be the wrong tool to stabilize the lung. PEEP may not be effective as a way of stabilizing the lung. And this actually occurs as you go up into the higher levels of PEEP. In fact, we're about to publish this, which is just looking at simply time. If you let the lung deflate and you control the time, you stop it. You stop the lung from creeping down, if you will, to losing lung volume. And then if you measure that pressure, then what you can do now is use that same pressure as your conventional PEEP. And you can see here, if I have a pointer here, okay. Let's see if this works. Okay, so here, this is the time control. This is the airway pressure in the dots. So here's the airway pressure. You can see we're going from a certain pressure, and in both instances we go down to around 15 centimeters of pressure. Now here the time is over, so you go back up. Now when you look at the alveolar change, so you see alveoli start to collapse. This is looking at in vivo microscopy. And then of course once the time is over, they stop collapsing because time's over. You're back into your pressurization phase. But even if you stay at 15 of PEEP, you notice the pressure is stable, but the alveoli continue to shrink throughout the whole breath. In fact, let's look at the video. Here is just a very brief time, and this generates 15 centimeters of pressure, roughly. Then we're going to take that same 15 centimeters, it's actually the same area of the lung, and we're going to use that 15 centimeters to try to control the lung. And we actually slow it down quite a bit so that you can actually see the alveoli. So PEEP may not be an effective method. Again, this is data we're about to publish. But also we published this paper, is that alveolar stability has nothing to do with PO2. I think you also showed this, Luigi. And that when we do the ARC trial, or we even look at the oscillator Oscar trial, we have endpoints of oxygenation to say the lung is now recruited, which may not be true. And in fact, we just published this paper where we argue that the lung is just inherently unstable. The geometry of your lung is an unstable structure. And so we need stabilizers. One of the major ones is surfactant. Alveolar interdependence or tethering, chest wall recoil. All these things are very important in maintaining alveolar stability. And because they are missing in some patients, just because you reopen the lung, does it mean it's stable? Actually, in this paper, we talk about a broken arm. We talk about a broken arm because obviously if one of us slips and falls and breaks our arm, we go to the emergency department, they reduce the fracture anatomically perfect on the x-ray, and they put a cast on us. The physician doesn't come back and say, okay, well, the x-ray looks great, let's cut the cast off. We don't do that because we know that even if you stabilize the fracture, align the fracture, it may not be stable until it heals. So the lung needs a certain amount of time to elapse before it is actually stable. You can't just achieve a PO2 for one blood gas and then withdraw the pressure or go from the oscillator to conventional ventilation and expect that the alveoli are stable. So recruitment and alveolar stability, in my mind, are two separate concepts. So I think this is a deeper question. What are the biological consequences of mechanical ventilation? And I don't want to say baby lung, non-baby lung. I'd rather say, what are we talking about? What is the functional unit of the lung that we're trying to protect? We're trying to protect that delicate ultrastructure. That's what we're worried about. So we might need to go there for an answer. Of course, that's more difficult, right? Because the ventilator is easy. You can look at some numbers, you can say a tidal volume, but does that really correlate with what's happening? In fact, this is what led us, you see a lot of viewpoints here because we do think that there's concepts that are not considered right now and that perhaps need to be considered. And that is, should we look at the microenvironment, not the macro? Most of the therapy we're talking about is macro ventilation, even transpulmonary pressure. These are global assessments of the lung itself. When we know one of the hallmarks of lung injury is the heterogeneity. We know the lung is heterogeneous. In fact, Luigi, again, thank you, Luigi, you made my job much easier, showed you very nicely how the energy can concentrate in parts of the lung. And so the question is, how do we understand that? And again, the ventilator isn't going to give us that information. In other words, the ventilator can be protective strategy. You can go home and feel confident that the ventilator is protecting the lung by looking at the numbers. But is it really? Is it protecting the lung at this level? And again, we in this paper, we actually use the correlation of the microcirculation and shock. We know that blood pressure, cardiac output, stroke volume, none of these parameters actually matter in terms of outcome. And that is not a linear function. In other words, you can have blood pressure, but the microcirculation is terrible. So are we still at a stage in ventilation that we are just focused so much on the macro parameters that we are not thinking about what's happening at a deeper level? Now, we may not be able to solve the problem clinically, but at least it helps us define the problem. Solutions are always better when you clearly understand the problem. So let's go back to this. Is the lung really a balloon? I mean, that's how a lot of people conceptualize it. And it makes sense to limit tidal volume, certainly if there's a volumetric distortion of the lung, where more pressure, more volume, stretches the balloon more, and so on. And unfortunately, this is a concept that I know we still teach in medical school, is that everything is grapes because of the Latin for asinus means grape-like. And so many years ago, people started drawing that, grapes. Very appetizing, but may not have anything to do with how the lung works. In fact, the lung is not anywhere near a grape or a balloon. In fact, the ultrastructure of the lung is important to understand the basic concept of how the structure really works. And one of the key things that's missing from the balloons, the stick on a balloon even, is that alveoli share walls. They're very interdependent. And that's what makes it very important to think about the lung and how it's made. So its geometry is more like a honeycomb. Let's just say that's the structure, and they share walls. So let's take a look at this. And this is why, actually, the lung is very resistant to collapse, and it's very resistant to overdistension, the normal lung. It's very hard to actually overdistend it. And the reason is if you add pressure on one side and you add pressure on the other side, nothing changes. Be like if we were pushing against each other, as long as we continue to increase the same way, none of us are going to move. It's only if I were to stop, you're going to fall forward. So that becomes important. And we also know that when you take a big breath, you actually do not have balloon-like distension. So when you go from your FRC, comfortably now, hopefully, to TLC, what you do is actually recruit more alveoli. You increase the number of alveoli, not the size of the alveoli. The size is actually very stable. In fact, again, I will tell you that as you get closer to total lung capacity, the alveolar diameter is smaller, not larger. In fact, here's, you can see total lung capacity. You can see the number of alveoli increases. Oh, I forgot my pointer. The alveolar volume is stable, but the number increases as you go from residual volume to total lung capacity. Actually, let's take a look at some microscopy. Now, this is an injured lung, but we're going to use 40 centimeters of pressure. 40 centimeters should surely over-distend some part of these alveoli. Now, watch what happens. Tell me if you see any alveoli over-distending, or if you see more of them just trying to recruit. You see, you might think this is a over-distending alveoli, but it's actually a separate alveolus right here. And there's another one. Here's another one. So we're holding the pressure at 40. Lung's not over-distending, at least not at the alveolar level. Now, again, I'm not going to tell you that stretch cannot be a biologic signal. I'm not saying that. But I will tell you that there's a recent paper that we did with a group from Brazil where we looked at a biomarker, amphoreglin, which is associated with overdistension. And we found that when you use higher plateau pressure in APRV, you actually have less signal for overdistension by amphoreglin. So here you can see that this is the same lung, just a little bit longer. You can see that over time, you're still going to recruit. You're still not blowing up the lung. So what about the tubes leading up to the lung? That's another important idea. Because if you think about the PEEP may not be able to keep alveolar volume. It loses alveolar volume, but where does that go? Where does the volume go? And in fact, if you think of it this way, is that this is essentially the alveoli and the alveolar duct, but when you blow up the duct, the alveoli actually get smaller. They just melt into the airway. That may be the reason why alveoli get smaller. It's a redistribution of gas in the distal airspace. In fact, to answer this question, we did a paper where we basically said, where is the air in the lung? And we're looking at the alveolar duct, and these are, of course, the alveoli here. And what you see here is green as the gas volume in the alveolar duct, and purple is the gas volume in the alveoli. And then, of course, you have red here, which is tissue density. So you can see that you've got the coloring here. You've got the alveolar purple, the ducts are in green, and so on. And so we looked at normal. So you can see that most of the gas is alveolar volume. About 50% of the distal gas space is alveolar. You can see all the purple here and very few ducts. Then you injure the lung. Once you injure the lung, the gas distribution in the distal airspace changes. And you can see here that you have APRV. This is what we would call APRV not appropriately set, where you let the pressure completely out. In other words, you basically let the lung de-recruit. So this has a high dynamic strain. And you can see that the ducts become enormous. Same thing with PEEP. In fact, what we found was when you increase the PEEP from 5 to 16, the duct gas increases, but not the alveolar gas content. So you have to go to the table, which I'm not showing you, but the purple is not different. The green is different with higher PEEP. So PEEP tends to increase the duct. Now the duct, if the lung compliance is very poor, will distend. Now let's get back to the tidal volume idea again. The tidal volume idea, we know that when people exercise, their tidal volumes are huge. Of course, their compliance is also normal too. So coming back to the driving pressure idea, because what we're trying to talk about is more normalization of the tidal volume to lung volume, and that it really shouldn't be a big percentage of your total lung volume. If you are doing all your lung volume is tidal ventilation, that's a problem, because the strain is tremendous. But if your tidal volume is big, but your lung volume is big, your compliance is good, another way of saying that, you can have tremendous tidal volumes. Where's our tidal volumes here? With severe exercise, 2.7 liters plus or minus. Here's some airway pressure parameters. I can't really see that very well. This is normalized for lung volume here, the pulmonary pressure. This is with esophageal balloons. So you can see that the normal lung can withstand a lot of pressure. In fact, the medical students in our lab decided to do a study. I asked them to just take the energy of calculation, which is just another way to understand how much energy you're putting into the chest and lung from the mechanical ventilator, and we can tie in a bunch of things. We can add tidal volume, because that would affect it, tidal volume size, respiratory rate, the airway pressure, the PEEP level, all those things you could put together and call that an energy that you are dissipating into the respiratory system. And if you look at some of the studies, it's 12-ish in some of the ARDS studies, plus or minus. Actually, here's a summary of that. But here is the energy in an exercising human, about 19 times higher than the ventilator studies. And again, the only reason why I'm pointing this out, and this is only published in abstract, and we're working on this, but the only reason why I point this out is that there's more to it than just what you do on the ventilator. You need to say, what is the lung we're ventilating? And that's actually a very individualized thing, because the patients are going to be different. So all these pieces of information are still not quite fine-tuned. And again, I'm not trying to make you, again, I made you sure you're not clinicians. We're talking to scientists here. So I'm not trying to change your practice or anything. I'm just trying to provoke more thought about what we do at the bedside and just point out to you that there's still a lot of gaps in our understanding of what's going on. In fact, besides energy, besides some of the themes you're going to see more of is stress concentrators, stress-strain relationship. This is perhaps a better way to define ventilator-induced lung injury. Perhaps you're going to hear more things about homogeneity, about alveolar instability. This is where a lot of research is kind of leading us down. And so what we did in this paper is just try to review alveolar mechanics. And what does the alveoli think about ventilator strategies? And so again, we start with this. And I just want to point out the normal lung, because we convect in our big airways, we actually physically move gas. But once you get past the terminal airways, it's all diffusion. There's very little movement. The lung actually doesn't move. In fact, the alveolar volume change between inspiration and expiration is 2 to 5%. Very little change in alveolar volume between inhalation and exhalation. So you can see there's a lot of alveoli, wall-to-wall alveoli, and they're very stable. They don't move much. So the only reason why I'm talking about this is because if the lung can endure that kind of energy during exercise, then maybe we can figure out what its secret is to protect it. Because the load on a ventilator, we may not be able to control as much as we think we can, because it all sounds nice. Keep the driving pressure low, do this, do that. It all sounds nice until the patient forces your hand to do more. And then, of course, you might consider ECMO, which is certainly not against ECMO, but it's certainly another invasive procedure. So we're now going to take that biology and we're going to map it to make it a little bit easier. And this is what your lung is doing. Again, this is the alveolar interdependence. Now, let's create a problem. Let's create a problem where some of the alveoli decide to become unstable. So their inflation is unstable. They may not inflate, or they actually inflate during the tidal cycling. So they're going up and down with plateau pressure. And again, we can't tell this clinically. We're looking at alveoli under a microscope. Because again, you can't look for oxygenation to tell you this. There's nothing on the ventilator that says, look out, you have alveolar instability, warning, the lights are going off. There's nothing like that. In fact, the PO2 may be fine. Because remember that your alveoli can open, completely saturate hemoglobin, and close again, because the transit time is so quick in the lung. So what happens if you create this? Now watch, and again, this is mimicking the biology, so it's just a little bit easier to see. Now watch what happens to the alveoli. And this is where interdependence becomes important, and you can't think of it as a balloon. They're actually starting to distend. In fact, there's more and more data from multiple researchers, not just our data, suggesting that without recruitment, derecruitment, you can't overdistend the lung. That's a prerequisite. That has to happen. And I also want to point out one other thing, is that when we look at the biology here, we see that the biggest distension of the alveoli is not during inspiration, it's during expiration. This may be why PEEP is so important, or getting PEEP right, or I should say, forget PEEP as a tool. Whatever tool we use, we need to ensure that the alveoli are stable during expiration as a way to prevent this. Now again, let's just show you, let's just do it this way. Watch what happens. See, when these collapse, you'll see that the other tissue stretches to fill the space. And that's during the exhalation, not the inhalation. So again, let's just map this out again. And this is going to tie in what Luigi mentioned before, is that we're going to look at again, this is mimicking the biology. We do this so that it's easier to illustrate. So what we're going to do is injure this lung and we're going to collapse it. In fact, let's focus on this part of the lung. And we're measuring the alveolar change, alveolar area change around this area of collapse. Now watch what happens when you collapse the lung. You start deforming it. And the yellow area is where the stress is going to increase. Now, interestingly, some other researchers, this is a group that's actually very active from University of Pennsylvania about this topic, and what they find is exactly the same thing, that when you recruit the lung with higher airway pressure, it reduces stretch, not increases stretch, reduces it. Again, kind of counterintuitive unless you just think of it as a balloon here and collapsed lung here. It's a little bit more. And the important thing here is that the overdistension is correlated to where the lung is atelectatic. In other words, once you create an unstable part of the lung, we don't have to argue about overdistension or recruitment, derecruitment. You get both for the single price. You only pay once, you get both in that part of the lung. And in fact, again, here, I'll just show you. Watch what happens when you recruit an alveolus. You see the other alveolus gets smaller. Did you see that? Is it playing again? No. Let me see if I can play it. Oh, there we go. I can start it again. Now watch what happens here. This, see? You see that gets smaller? And again, so the bigger the lung or the bigger area, you can dissipate energy forces. Maybe the lung will be protected that way. Maybe the secret is homogeneity and alveolar stability. That's exactly what your lung does when you go for a jog. In fact, again, we're back to unstable inflation is where the lung injury begins. It is these areas of collapse. Now, just do remember that we are very good at collapsing lung in the ICU and in the operating room. As soon as we control people's ventilation, as soon as we make them supine, as soon as we sedate them, all those forces end up causing collapse. Once you cause collapse, we know, actually, data I'm not showing you from PET scans, we know that the inflammatory region is right where the interface between the collapsed lung and the healthy lung is. And that's where you're also going to have local overdistension. So this is actually, I think, an important paper. This is another important paper, again, using CAT scans. Just do remember, CAT scans don't have the sensitivity. I think this is interesting. It's very, where is it? Using different techniques. We have MRI, we have helium gas, we have different techniques that perhaps give us a little more definition about what's going on in the lung beyond CAT scan, because a CAT scan may underestimate some of the things. Now again, a CAT scan, again, has helped us beyond our initial thoughts. I think back to when I was in training, we didn't care about airway pressure. The only thing we cared about was, or anything on the ventilator, we only cared about the blood gas. We thought that if you could make the blood gas look good, that was all you needed to do. And I believe that's clearly wrong. Now we think if you make the ventilator look good, that's all you need to do. I still think we're wrong. At some point, we're going to talk about the patient, and we're going to try to figure this out. But ultimately, I think we need to have a much deeper understanding, and I think it's coming because the techniques are getting better. So we went from a plain dimensionless chest x-ray to a 3D concept of the lung and how it's not just all white, that there's some areas that are different and the heterogeneity. And of course, the trick is to figure out how to ventilate them all properly with one single breath. And that's certainly a big technique. So I think the tidal volume story is just part of it. It's just the very beginning of our understanding. We still have, in my opinion, a very long way to go. Now, I will tell you about a study we did where we tried to do this a little bit. And what we created this model, which actually I think a lot of people are happy with. What we ended up doing is creating a baby lung. So we took pigs, and with a bronchoscope, we instilled tween in the dependent parts of their lung. And so these are normal lungs otherwise. So surfactant, so the lung is recruiting, de-recruiting, because all the surfactant is destroyed with tween. So we have a lot of recruitment, de-recruitment in the base of the lung, as you can see here. And then the rest of it is totally healthy. This has never been. So we created a model where you have the baby lung and you have the diseased lung. And now what we're going to do is test the idea. In both groups, you're going to get distended to 40 centimeters of pressure because we want to destroy that lung with overdistension. The 40 centimeters is serving as a way to overdistend the normal lung. And what we're going to change now is how much dynamic strain or recruitment, de-recruitment between groups. So all groups get 40 centimeters of water to their normal lung and abnormal lung, and we're going to look at the difference. And again, one has a high dynamic strain and one has low. And if this is the high dynamic strain is in white and the low dynamic strain is in black, and this is the baby lung because it's normal lung versus acutely injured lung. And you can see that if you look at wet, dry weight. Now remember, both, if we look at the baby lung, the baby lung is getting 40 centimeters of water, but if you have low dynamic strain, you actually have less lung water. And of course, the injured lung is also a little bit better as well by eliminating the dynamic strain. So it seems as though the dynamic strain is important for both the normal lung, or the baby lung, and the diseased lung. Let's look a little bit further. Let's look at protein concentration here. This is, you can see this is, I want to say this is surfactant A. No, that's surfactant A. What is that? Okay, this is, I'm sorry, this is just how much edema is in the lung, proteinaceous edema. And you can see that, again, the high dynamic strain, the baby lung, sorry, this is the baby lung, high dynamic strain, baby lung, low dynamic strain. So you can see a difference in how much exudative edema there is. Again, both of these baby lungs are seeing 40 centimeters of pressure. What we're varying is how much collapse time there is. And similarly with the lung injured area. If you look at protein A, again, you've got the normal lung, and here you have better protein A with, even though again exposed to 40 centimeters of pressure, you have better surfactant protein A signal. And surfactant B didn't reach statistical significance, but again, you can see a better level of surfactant B when you compare this in the normal lung. Again, here's some inflammatory markers. Here's the normal baby lung, here's the normal baby lung, and the injured lung, and so on. So dynamic strain in this study seems to make a difference, even though the distending pressure is still 40, even though we've created a baby lung very similar to what you would see clinically. And of course, here's the gross pathology. This is the low dynamic strain, and this is high dynamic strain. Both groups receive 40 centimeters of pressure distending their normal lung. Let's look at the histology. Again, you can see the histology. This is the normal lung. This is with high dynamic strain. This is the baby lung with low dynamic strain. And this is the injured lung. So in both areas, the lung is better protected when you control dynamic strain, regardless of the distending pressure. Again, this doesn't prove anything, but it does suggest that there's a lot more to the story than just simple tidal volume. So I'll stop there and see if there's any questions. Thank you.